Hello, everyone. I'm Pam Cipriano, President of the International Council of Nurses, and I'm really pleased to welcome all of you today. And thank you for joining our webinar on mental health nursing, which is, as you know, is a critical issue for all of us today. So we're going to be talking about transforming the future of mental health care. Just to review the instructions for the beginning of the webinar, we are providing interpretation services in English, Spanish, and French. So make sure you select your language using the interpretation icon at the bottom of your screen. For comments or any greetings, please put them in the chat. And then if you have any questions, please put them in the Q&A, and we will do our best to answer them throughout the webinar or following the webinar. So today we're launching ICN's new guidelines on mental health nursing. This is a major step forward for our collective mission to improve mental health care globally. Let me just refresh your memory of some major definitions that have guided our work for many years. The first is the WHO definition of health, because we all believe that health is a human right. So in the preamble to the Constitution of WHO, which we're very familiar with, that health is defined as a state of complete physical, mental, and social well-being, not merely the absence of disease and infirmity. And WHO goes on to describe mental health as conceptualizing it as a state of well-being in which the individual realizes his or her own abilities, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution to his or her community. So we acknowledge that mental health then is also a universal human right. We believe human rights considerations really need to be at the forefront of mental health care. People who suffer from mental disorders have the same rights as anyone else to live free of discrimination, violence, and stigma. Now, we all know all too well that the world has woken up to the dramatic need for mental health services. The pandemic sounded the alarm, and the toll that death, stress, fear, and fatigue, as well as moral injury, was exacted on nurses and many other healthcare professionals and all of the individuals providing care. And we know that the recovery and healing from those unprecedented experiences is only just beginning. And the slow progress is really a threat to the entire workforce and the patients and communities that we serve. You know, 1 out of every 2 people in the world will develop a mental health condition at some point in their lives. But over 70% of people in the world with severe mental health and substance use disorders receive no treatment. And it is really skewed, particularly in low and low middle income countries where very few people are getting the treatment they need. So what we do know, though, is that the evolving landscape for treatment highlights the critical role of nurses, all nurses, with a particular emphasis on mental health nurses. We know that mental health nurses are at the forefront, providing compassionate care for responsive healthcare systems. So the question before us today, can we really transform mental health care through nursing? We want all nurses to recognize their roles and responsibilities in this movement. Why? Because there are barriers. We know there's not enough services or providers. We know there's not enough social support. And we know that stigma is a significant force against providing the right mental health care for individuals seeking care. So we have 2 crises. We have the burden of mental health disease and the shortage of persons with mental health services and education of those who can provide care. So today's webinar is going to focus on taking action and introduce you to some of the tools and plans available to stimulate your thinking and support your actions in your own country. You'll hear about a number of groundbreaking reports over the last couple of years that, again, give us great guidance on how to really approach these issues and make sure that we are supporting the role of nurses. So today, as you learn more about the mental health guidelines from ICN, this is also an opportunity to hear from and engage with a panel of world-renowned mental health experts who will focus on advocacy for a rights-based, ethical, and compassionate approach to care as well as the urgency to take action for the health of all people. So let me introduce our first speakers, and they will be Dave Stewart and Dr. Madeline Nagel. Dave Stewart is the Deputy Chief Nursing Officer at ICN, and he has been with ICN since 2016 and leads the health policy team. Dr. Madeline Nagel is a professor emerita at New York University and a global mental health consultant. Both Dave and Madeline were involved in the writing of the most recent guidelines. And Madeline is a distinguished figure in addiction and psychiatric nursing, specializing in older adults, a leader in integrating behavioral health into education. Dave, over to you.
Thank you, Madam President. It's a great honor to finally get to this part where the guidelines are being launched. It has been a long journey. It has been a worthwhile journey, though, getting here. And I must say that I must give a great big thanks to some of the key authors and amazing mental health nurses around the world that have helped the development of this. But in particular, I want to thank Madeline, who you'll hear from very shortly, but also from Espen Roland and Francis Hughes and Kim Ryan, who gave of their time and their energy to help us steer these guidelines to where they are today. But not only that, we have gone through nearly 60 countries interviewing experts from so many different places around the world, trying to make sure that their thoughts are heard. And what has come through resoundingly is the passion for better healthcare, particularly for those needing mental health care. And that passion as people have given of their time and their energy to ensure that we have tried to give the best product that we can possibly do. And echoing the words of the President, we know that there can be no health without mental health. And we recognize that nowhere in the world does mental health enjoy the parity with physical health in national policies, budgets, or in education and practice. It is indefensible that people cannot access good quality care, because it is a human right to have the highest attainable standard of mental and physical health. I want to pass over to my wonderful colleague, Madeline, who is one of the authors on these guidelines, to present a couple of insights from these. So Madeline, Cyril, would you mind bringing up the presentation for us today? And Madeline, thank you very much.
Yes, good morning. Good morning, Dave. Good morning, everyone. It's my pleasure to highlight some of the key points behind this document. But I first would like to acknowledge the leadership of ICN, and particularly Dave Stewart, in taking us through these last 2.5 years of repeated initiatives where we refined the document in ways that we felt it would have broad applicability. Especially important to that contribution to the guidelines was the review by mental health experts from around the world, from representing more than 40 countries, where we heard from people, about the applicability of these guidelines to their cultures, to their resources, educational and financial. And it speaks, I would say, very positively to the importance of these guidelines, that we now have 1,400 people attending that seminar today. So if we could go to the slides, I'll talk a little bit about some of the highlights, some of the key points that we felt made this document forward-looking and transforming what we hope will be mental health for the future. So if I could have the first slide. So Dr. Danius Pouris started his thinking about mental health with this particular quote. He noted that too much time, money, and effort was going into medical models that did not necessarily serve our populations well. We as nurses know that it's the interpersonal work, the interpersonal therapies, the efforts to manage care, the efforts to get patients to the right resources that really take us forward. So one of the points we will make very strongly in this document is that we want our nurses to be well prepared to do what they can in interpersonal ways to use the systems that they have, whether they're very complex or whether they're very basic, to get people the care they need. Next slide, please. So the purpose of the mental health nursing guidelines are to really promote consensus on practice standards. We have a great vision before us. We're not all in the same place, but what brings quality consistently to the recipients of our care is that we've agreed on certain practice standards and that we will teach to help our students reach those practice standards on graduation. We want to urge more nurses in their communities, no matter how small, to raise a voice when plans are being made about healthcare delivery and about mental health care delivery, to be on a council, to be in a small group, to be in a neighborhood group, to be in a nonprofit where nursing has a voice. We want to have the kind of consistency and quality care that can be delivered when we have A, standards, and B, like thinking among our nursing leaders. And ICN has given us a great model in that. But by putting forth the guidelines, there is a reference point that every country, even though working at different levels of achieving those goals, can use as a reference to move ahead with education and practice. Research indicates to us that when we do have well-prepared nurses, and when nurses are working as teams, and when they have as high level of education is available to them, we're talking particularly about the baccalaureate, we have improved health outcomes for our patients. Next slide, please. I've put leadership at the top of this list because while we have a variety of nurses working in the field, all nurses are educated to some degree in leadership. They understand what leadership can be. They are encouraged to express their own opinions, to act on their opinions. So whether you lead a team on the unit in the hospital, whether you're the leader of a community-based team where you're the only registered nurse, or whether you're the leader of a national or international association, that leadership provides a voice for stating views supported by national and international standards for nursing that we can all support. Registered nurses are the first people who really deal with mental health. And while their skills may not be at the level expert enough to deal with complex, serious mental illness, each one of them knows how important the mental health of patients is. And through supportive interviewing, by doing basic nursing assessments, they identify where mental health nurse interventions are necessary. Our specialists in mental health nursing are certified. They are prepared at different levels in all countries. We do consider them the expert, and they are sought as the experts. The advanced practice mental health nurses, who are growing now in about 30% of countries where we have some models of those practice, have master's degree levels or beyond, and perhaps certification, which speak to their additional education and experience. It's a model that is interpreted in a variety of ways among our ICN members. It's a model that we have some flexibility on, but it gives us a model to which to aspire, where our experts are able to draw on theoretical knowledge, clinical knowledge, and the collaborative work with other mental health providers to provide the best care. Next slide, please. The variety of practice settings in which our mental health nurses work, and more nurses are working in communities, they're working in corporations, they're working in nursing homes, especially important for mental health nurses. And we want to have the flexibility to move in those spaces. The characteristics of the work remain at their heart: standard, nursing practices based on nursing knowledge and nursing theories and what's gone before, but also introducing innovative therapeutic tools such as psychotherapy. Scope of practice varies from country to country. We want scope of practice to be a standard so that within each country, the nurse complies with the expectations designated by educational institutions and boards which regulate practice. Next slide, please. The power of the nurse-patient relationship has been there from the very beginning of time. And we could go back to talking about the mental health interventions of Florence Nightingale in the Crimea. Some of you may know that she, in caring for the soldiers, noticed that the soldiers were spending much too much money on alcohol and not sending it home to their families. So a very basic mental health intervention was she developed a means to have certain portions of the soldiers' financial reimbursement sent directly back to England. They had some monies to use, but they didn't have the money to spend on alcohol, which was being consumed in great amounts in those numbers. So that was one of the very first mental health interventions that we know about, and it was done by the woman we consider to be the mother of nursing many, many years ago. Nurses know how to build trusting relationships. They have the patience to build them. And within those trusting relationships, they use interpersonal as well as advanced psychotherapeutic skills to provide emotional, psychological, and psychosocial support. They promote problem solving so that patients take on their own issues with new initiative and apply the knowledge that they have gained in treatment, but the knowledge that they have through their own lives to change their behavior and to move ahead to deal with the problems, difficulties.
One more minute to go, Madeline.
Okay, next one, please. So the focus of education should include the entire continuum of care. We're focusing on competency-based education, and competency-based education combines the use of theory and clinical practice, but really does also require the assessment of the skills by the students so that we see that they are able to do that. We promote person-centered and rights-based care, and we place high value on education and funding for educations. Next slide, please. Evidence-based care has been increasing in amount and is available to nurses on digital platforms all around the world. It's going to help us improve access to care. It is focused on the whole person, and research is showing us, not just in nursing arenas, that it's improving the cost effectiveness of care. I think we have one more slide. So let's not forget that nurses cannot give good care to their families, to their patients, or in the support of their colleagues unless they know something about self-care. They need to be well nourished. They need to be well rested. They need to have working conditions that provides the time they need to get the kind of physical and mental health care they need. They need peer support groups. So that's right first and foremost in the policies that we've been promoting through ICN in the last 2 years. And we ask that all of you begin to think about how that might be more visible in your programs. So thank you for these few moments. I look forward to being back with you later in a panel discussion.
Thank you, Dave, and thank you, Madeline, for introducing the ICN guidelines on mental health nursing. And the links have been put in the chat for the document in 3 languages just being released today. I would now like to introduce our next speaker, who's going to talk about the value of integrating lived experiences in mental health. And our speaker is Charlene Sunkel, the founder and CEO of the Global Mental Health Peer Network. She is a global mental health lived experience advocate and has authored and co-authored a number of papers related to mental health and human rights. Charlene?
Thank you so much. It's a real honor for me to be part of this important event. And I do congratulate you on the launch of this guidelines. So let me just share. So you can all see my slides. So I just want to start off by saying that my journey as a person with lived experience of schizophrenia really led to me establishing the Global Mental Health Peer Network. Just to quickly show you overall the profile of the organization. We've grown into quite a large organization in a matter of 5 years. You can see we are 100% lived experience. And by that, I mean from our board, our staff and all our members, even our volunteers. We have quite diverse representation in terms of income per country, majority being from low and middle income countries. We started to push a lot to include young people in the organization and see that we have 50% young people, and that between the ages of 18 and 34 across ethnicity. And what was quite surprising for me is that we could always maintained a higher percentage of women in the organization, especially considering from middle income countries at 64%. So currently we are represented in 49 countries with 156 experts by experience. As we evolved, we came to realize that we really need to become more efficient in the way we work. So we established 7 specific units within the organization. And the first 3, the experts by experience consultancy services, is actually a unit that we established to provide lived experience expertise to various sectors. And our P2P unit, which involves peer-to-peer mentorship, through which we empower our members to actually advocate and really to equip them to advocate for integration into all sectors in mental health, but also in society. So that is where the empowerment and development happens. We recently established Youth Agents for Change, that is to emphasize and amplify the voices of young people in mental health. And then we have peer support, which we provide internally to our members. And of course, communications and awareness, where we do use our own lived experiences to raise awareness on public online platforms. And then our special projects unit, currently we run a project where we are busy developing a costing model for lived experience expertise, the remuneration of that to come to a fair and equal compensation amount for the different roles that people with lived experience play. And of course, then our more organizational development and sustainability unit. Then next slide. Okay. Oh, sorry. Next slide. Here we go. Just to show you kind of the latest statistics in terms of where our lived experience expertise, where we provide specifically our services, consultancy services. We've done to governments where we mainly provide inputs and review and draft policies and legislation. We provide services to the non-profit sector in various workshops and collaborate in providing inputs into their materials. International agencies, we often work with the World Health Organization. What's new is we see quite an increase in working with donor and funding organizations, where we provided some review of their funding strategies. Corporate sectors mainly focused around workplace mental health. And then what was quite interesting is that we've seen quite a huge increase in services provided to academic and research institutions. So that involves a lot of more involvement as collaborators in research projects.
Charlene.
Okay, plus doing lectures to health professionals. And just quickly to run through this, the value actually of lived experience is we do have a unique and in-depth knowledge of understanding based on our own mental health conditions. Because we've navigated systems, we understand what is needed to really remove the barriers to equality and equity, and also stigma and discrimination-free communities, barriers to inclusion, sustainable development, and to protect mental health for everyone. We're also able to help and guide in terms of reducing coercive practices and understanding how what is necessary to improve the conditions to make it more possible for recovery, and of course to provide cost-effective and practical solutions to enhance effectiveness of mental health and especially referral systems, and also to help policymakers to strengthen and mainstream mental health into other sectors. And then, of course, particularly through service delivery as peer support specialists. And just last slide, to mention some of the key elements of principles of effective engagement. When working with people with lived experience, it's important to consider diversity and equality, mutual respect and trust. There's no power imbalances, non-discrimination, and absolutely no tokenism, empowerment, and to value people's contributions. And I thank you very much.
Thank you very much, Charlene, for raising our awareness on the importance of making sure that the lived experience is part of our knowledge of better delivery of mental health care. Next, I would like to introduce our speaker who will address key opportunities for nursing to support mental health. This is Professor Sir Graham Thornycroft. He is a professor of community psychiatry at King's College London. He's also a distinguished figure in mental health and has made significant contributions to England's mental health policy and chaired key initiatives at the WHO. Sir Graham is a global expert in reducing stigma, evaluating mental health services, and advancing global mental health. Professor Thornycroft.
Madam President, thank you very much, and good day to everyone. It's so exciting to see people joining the meeting from all around the world. I'd like to say a little bit about opportunities for nurses to directly and indirectly contribute towards mental health. I'm going to start with an idea called the mental health gap. One part of this is the question about how many people, as we heard from the President, actually receive treatment, people who have mental health conditions. We know that these conditions are enormously common. About a quarter of us every year have such a difficulty. 3/4 of us know somebody, a friend or a family member, with a mental health difficulty this year. But the large majority of people with such difficulties receive no care or treatment. For example, among people with severe depression, even in the rich countries, only about a quarter receive treatment, and in low and in middle income countries worldwide, it's less than 5%. Now we know that the nursing workforce across the whole world is large and increasing. Some would say it's one of the most important sectors of person power to deliver health. Some would say it's actually the most important sector in healthcare. But we also know that there are relatively few specialist mental health nurses. You can see a recent report from the ICN found that between 1% and 3% of all nurses worldwide are trained as mental health nurses. An idea about how to go about addressing the scale of this challenge comes in this, the most recent comprehensive mental health plan from the World Health Organization. And one question is, well, who should provide mental health care, assessment, treatment, sometimes referral? And in the large majority of countries, because specialists such as psychiatrists and psychologists, and indeed mental health nurses, are so few on the ground, it is those nurses and general nurses who are in the pole position to provide mental health care. In fact, it's the only group in sufficient numbers across the world to provide care in relation to the scale of need. One important tool is this, produced by the World Health Organization, called the MHGAP Intervention Guide. You can see that there are 3 editions of this, the most recent one published just a couple of months ago. It's a guide deliberately including bio and psycho and social approaches to supporting people with mental health conditions, especially focused upon the needs of people where 85% of the world's population live, that's in low and in middle income countries, and designed to be practically usable, very, very practical and very, very usable by individual practitioners, including nurses and community health workers and nursing assistants and auxiliaries, as well as other people such as community health workers. Indeed, this guide is designed for non-specialist staff. The guide has now been used in over 100 countries worldwide, and there's good evidence accumulating, over 200 papers now looking at this, that there are positive impacts of using this particular practical set of guidelines. If you haven't had a look at it, you might want to. It's available from the WHO website, free, in all the usual WHO languages. Second, I'd like to say a little bit about stigma and discrimination. As we heard from Madam President, this is a serious set of barriers stopping people getting the care and support needed. It infringes basic human rights. It's toxic upon people, both people with mental health conditions and family members. There are a whole range of types of social exclusion stemming from stigma, including not just barriers to mental health care, but barriers to physical health care, contributing to worse physical health outcomes and poorer life expectancy. It limits education and employment prospects, and of course also affects people working in the mental health field, including specialist mental health nurses. Now, this isn't only of a theoretical issue for me. My mother was a nurse throughout her career. She worked as a community nurse in the centre of England. And you can see on the right here, a little boy. Well, that's me when I was 3. And the reason I show this is that at that age, my mother developed a severe episode of depression. Indeed, she was suicidal for a while, and the medication she had didn't help her, but she had electroconvulsive treatment, so-called electroshock, which did. And the doctor who treated her then said, "Madam, you will never have depression again," which is a very bold statement. But in fact, it was true. She never did become depressed again. But when she was off work for a year, she did not tell her manager why she was off sick, because she thought if she said it was mental illness, she would get the sack and lose her job. In the last couple of years, it's been my pleasure to co-lead with Charlene Sunkel, you heard from a moment ago, the Lancet Commission on Ending Stigma and Discrimination in Mental Health. This is a great deal of detail about what is stigma, what can we do, but I can boil it down to 2 words. Use social contact. What does this mean? It means the evidence is clear that the way to reduce stigma and discrimination is to arrange for different ways for people who have experience of mental health conditions to have contact with people who do not. It could be direct contact or it could be indirect, for example, online, remote, digital, or social media. But it's the social contact which is the primary active ingredient for stigma reduction. And this has an important consequence, which is people with lived experience of mental health conditions are the central change agents for stigma reduction. One part of how to reduce stigma is to be careful with the words we use. For example, not saying schizophrenic or the equivalent in your language, but maybe to use a formula, person with. This has been used, for example, for people with HIV and AIDS, and similarly, it could mean saying a person with depression, or when in doubt, talk to people locally, people with lived experience of mental conditions, and say what words, what phrases do you find acceptable? Do you find respectful? Now, the co-production approach directly involving people with mental health conditions can come up with interesting solutions. This is a project led by my colleague Palab Maulik in India. It's a project to reduce stigma among young people, teenagers living in slums, and also to help people who are depressed receive care. And here you can see a game devised by the young people with a stigma message. Finally, then, a couple of resources. If you're interested in working with people who have both mental and physical health conditions at the same time, which is extremely common, WHO produced guidelines about how to do that. Again, very practical, clinically orientated guidelines. If you're interested in what to do in the workplace to promote mental health and to help people with mental health conditions to receive treatment, including disclosing in a safe way, there are also recent WHO guidelines which are very helpful. And the final resource I want to mention is ourselves, healthcare staff. In this case, nurses. These are data from the COVID period. And it found early on in the pandemic that you can see about a half of all the health and social care staff had anxiety, about a half had depression, about a quarter had post-traumatic stress disorder, and altogether, over a half, the majority of staff had at least one of these conditions. So we have to pay attention to our own needs as healthcare practitioners, for you as mental health and health nurses, and look after ourselves carefully so that we are a sustainable resource. So I've wanted to say a little bit about the mental health gap and the central role played by nurses in addressing this gap. A bit about stigma and discrimination, and remembering, please, just these two words, social contact, and a bit about some of the many resources available to you now as nurses show leadership in tackling mental health and working for better global mental health. Thank you very much for your attention, and please do contact me if you'd like to follow up any of these points. Thank you, Madam.
Thank you so much, Professor Sir Thornycroft. You did have very well brought information to us about how nurses can reduce these gaps, as well as how they can be more supportive in their personal interactions and communication. So thank you very much. We will next hear from Dr. Michelle Funk, who's going to share with us WHO work in mental health policy, law, and human rights for mental health, and WHO competencies for undergraduate education in mental health. Dr. Funk is the unit head of the WHO Policy, Law, and Human Rights team in the Department of Mental Health and Substance Use. Since 2000, she's been responsible for establishing the global framework for supporting countries to develop their mental health policies, laws, and services. She has created and leads the WHO Quality Rights Initiative, which works with countries to create and transform their mental health services to ensure quality and promote human rights. Dr. Funk.
Thank you so much. Hello, everyone. And thanks again to the ICN, Pamela, Howard, and David for the invitation here. I want to express my congratulations with the development of these new mental health guidelines. They are really comprehensive, and it's so good to see that they have such a strong grounding in the human rights-based approach. And essentially, it's this approach that I will be speaking to in my presentation. Our work at WHO in mental health spans many different areas, projects and initiatives. But due to the time limitations, it's not possible to cover everything. Graham has already mentioned our comprehensive mental health action plan and the MH gap. So instead, I'm going to be introducing some of the joint work that we're doing in collaboration with ICN and also the Royal College of Surgeons in Ireland. And some of this work is going to be rolled out amongst nurses globally in the next 4 years. Okay, the next slide. I'm having problems navigating. There we go. So first of all, I just want to start with a couple of positive messages before going a bit into the negative. We definitely are seeing renewed awareness about mental health and its importance. A lot of that, as Pamela said, stems from the COVID-19 pandemic and our shared experience of the negative impacts of the COVID lockdowns, and in particular, the social isolation that the lockdowns brought to bear. Of course, there were many other negative aspects related to mental health as well, reduced access to services when people needed them most, and many others. But certainly it's brought about a positive change in that everyone is talking about mental health now. We also see a growing number of initiatives and actions moving towards a holistic, person-centered and rights-based approach in mental health. So this is the new agenda for mental health. This is the transformative agenda that we want to see happen. However, even with this transformative agenda gaining momentum, there are so many challenges and pressing issues that need to be overcome, and I've listed them on this slide. It's institutionalization, the lack of access to community services, the large-scale use of coercive practices, violence, abuse, and neglect associated with the mental health services, the systematic denial of people's legal capacity, people's right to decide over their own treatment in other areas of their life, stigma, discrimination, and disempowerment that many people experience in the mental health services. I mean, it's quite common that once someone receives a diagnosis in the services, that they are seen as unable to contribute to society as many other people are able to. So basically they get stigmatized, they get labeled, stigmatized, and then perceptions about what people can achieve are limited. We also see the overemphasis on the use of diagnosis, use of medication to manage symptoms, rather than providing a more holistic, person-centered and rights-based approach. So these are all important challenges that have to be overcome. And there are many different levels in which we need to work. We've heard already about the need to combat stigma and discrimination, but it's more than that. It's also about promoting a human rights-based and recovery approach and attitudes and practices in the services. We also need to create more community-based services and supports that respect and promote human rights. We need to promote the participation of persons with lived experience and promote the engagement of civil society. And of course, we need to work at the level of national policy and law reform in line with international human rights standards and the CRPD. So these are all areas that we're working on through the WHO's Quality Rights Initiative, which aims to produce that transformative change in the mental health field that I and other speakers have been talking about. But however, if we're truly going to make progress in any of these reform areas, we really need, as a first and urgent step, is to promote the wide-scale mindset change in line with a human rights-based approach and reduce stigma and discrimination. And if we don't take action to achieve this mindset change, then there's a real risk that any new policy, law, or services that are developed might be a slight advancement of the previous ones, but without any fundamental change in the paradigm. So in this situation, old models and practices will continue as before. So we've developed at the WHO a wide range of tools as part of the Quality Rights Initiative. It covers many of the different areas I mentioned on my previous slide. But what I want to do is to focus on the Quality Rights e-training, which has been developed specifically to promote the mindset change for reduced stigma and discrimination and the human rights-based approach. You can see that highlighted in yellow. Of course, I don't know if anyone has access to put that in the link, but definitely can follow up later to get the link. The training is open and free to everyone and currently available in 13 languages, including English, Spanish, and French, with several more languages coming in the next several months, Slovenian, Portuguese, and Lithuanian. Unlike in-person training, which requires considerable human and financial resources, the Quality Rights e-training can be completed online at people's own pace. And as a result, we have the potential to implement capacity building at a huge, massive scale, reaching hundreds of thousands of people inside and across country. So obviously, this is a much more cost-effective approach than face-to-face training, which is limited in reach. Here are the different modules of the e-training platform. You can see that it builds, each module builds First on human rights, another one on human rights, mental health and disability that tackles directly stigma, discrimination, and the rights-based approach and different ways of looking at mental health. Then another module specifically on legal capacity and the right to decide and how to make that happen. Another on ending coercion, violence, and abuse. Another on what makes quality services and how we can promote community inclusion, and also another one, mental health, well-being, and recovery. So how does this e-training translate into practice benefits for nurses? Specifically in relation to the nursing workforce, the training helps nurses to take care of their own mental health, to support friends, family, and colleagues with their mental health, to provide mental health support to people as they recover from a physical or mental health condition or crisis, and in the context of their work, to help also tackle stigma, discrimination, and the use of coercive practices, actively involve people in their own treatment and care, and to transform the services in which nurses are working towards a person-centered, rights-based and recovery approach. It's stuck again. Okay, once a learner has completed all the training modules, they receive this official certificate from the World Health Organization, and through our collaboration with the ICN.
A minute to go, Michelle.
Thank you. And through the collaboration with the ICN, the Quality Rights e-training is recognized for 24 ICN educational credits for those who complete the training. And as everyone knows, this can help enormously towards professional accreditation and licensing. Here's some figures: 120,000 enrollments plus, over 50,000 successful completions, published paper with a 40% improvement in overall attitudes towards a rights-based approach and reduced stigma and discrimination. So it's definitely producing massive evidence-based results. So we can achieve wide scale change. Just to quickly mention our collaboration with the RCSI, the Royal College of Surgeons of Ireland, we're looking at in-depth the impact of the quality rights e-training amongst the nurse and midwifery population. Together with a collaboration with ICN and RCSI, we expect to be able to reach 5 million nurses and to improve the lives of over 500 million people experiencing mental health challenges based on the results. So I'd like to end here, sign up, do the training, and follow the ICN mental health nursing guidelines, and hoping everyone is able to make mental health a priority in their work. Thank you very much.
Thank you very much, Dr. Funk, not only for providing the tools and training that will help many people, but also helping us assure this transformation of mental health care. So thank you so much. Next, I would like to introduce Howard Catton, the CEO of the International Council of Nurses, who's going to talk with us about the mental health nursing workforce. Howard, over to you.
Thank you, Madam President. Good afternoon, good evening, good morning to all of you. You're very welcome. We're delighted to have so many of you online. The response to this webinar has been huge, which just goes to show the priority that nurses around the world hold this topic in. My job is to now is just to give you some insights into what we know about the mental health nursing workforce. First point to make is we don't know anywhere near enough. Data is limited, and we think that many countries and organizations are simply not focusing sufficiently on this hugely important part of the workforce. But I am going to share with you some of what we do know. Next slide, please. Graham showed a picture of this report, be familiar with very many of you. The State of the World's Nursing report produced in 2020 from data collected in 2018-2019 work we did with the World Health Organization. From this report, we know that at the time we had a shortage of about 6 million nurses globally, a total population of pushing about 29 million. But this image from the report also tells us something else which is very significant. We have maldistribution of nursing workforce right the way around the world. In countries that are in blue, they have 80, 90, 100 nurses per 10,000 population. But in those red countries, less than 20 nurses per 10,000 population. We have a maldistribution in the nursing workforce, but if I were to also put up here an image of health needs across the world, it would be virtually a mirror image, the inverse, that we have fewest nurses in the places of highest need. This image also tells us something of interest in relation to the countries that are currently at the forefront of recruiting nurses around the world, are overwhelmingly those that you see in blue on this map, those countries who have comparatively more nurses. Next slide, please. So we have a 6 million global shortage. We know that nearly 5 million nurses are due to retire in the next 10 years. You follow the arrows, you then come to two reports that ICN produced, one in 2022, one in 2023, collecting all of the evidence that we collated in relation to the impacts of the pandemic on the global nursing workforce, covering physical impacts, but importantly and really significantly, mental health, distress, injury, psychological and mental health harms as well. The President and I were just with 12 of our associations from places as far afield as Australia, America, and the UK last week, who were telling us about how those mental health impacts have remained with many of the nursing workforce in those countries and are being exacerbated by poor and inadequate workplace environments. The health and well-being of nurses' mental health is a hugely significant issue, and we're concerned that it could also be driving an increase in shortage. And then you follow the arrow to this last slide where it indicates, no, back to the follow the arrows to the end here, where there's the 30 million figure. This comes from a report from the University of Washington, who looked at the need for nurses. And you'll think, well, there's a huge difference. 6 million nurses from WHO, but a University of Washington report says 30 million. I think this is important for us to note this calculation because it is based on a more ambitious view of universal health coverage. The researchers for this report looked at including a wider range of services and greater coverage in their calculations than was used in the State of the World's Nursing report. And that therefore very clearly tells us the more healthcare that we look to want to provide, overwhelmingly, it's the nursing workforce who are going to be at the forefront of who we need to deliver that. This also clearly flags the importance of mental health, which, if we look at the SDGs, SDG 3, you'll be familiar with on health and well-being. It focuses really on maternal mortality, communicable disease, reproductive health, vaccines. Mental health visibility is low. Next slide, please. The image here is the report that Graham also highlighted and from which much of this data that I'm sharing with you is taken. I'd encourage you to look at that report as a compendium alongside the new report that we're launching today. It goes into more detail about the mental health challenge. You've heard a lot of this already, but Graham said, you know, every year 20% of people will experience a mental health issue. Over the course of lifetimes, 1 out of every 2 people in the world will develop a mental health disorder. I heard some of you will have just recently that it's about the same ratio for the numbers of us who will develop cancer over the course of our lifetime, 1 in 2. But then look at the next figure. 71% of people with severe mental health or substance use disorders receive no treatment at all. Can you imagine the outcry, the reaction, the response if 71% of people with stage 3 or stage 4 cancer received no treatment whatsoever? ever. So there's a huge discrepancy and inequality in terms of access to healthcare, which costs us, estimated to be up to more than 16 trillion. But given that there is that value for money from the investment, still countries are spending less than $2 per person, even though we know that there is a positive return on investment as well. This situation also flags for us, I think, an important point about what the consequences of these unmet needs are. Of course, there's a huge impact on individuals, but I think we all know that families and close friends then carry a huge supporting role, an additional supporting role as well. But we also see other services, police, social services, for example, in countries who are then having to try and pick up areas of support which quite frankly are not within their remit. Next slide, please. Graham had also indicated that from our report, out of the 29 million nurses, we believe that there are about 300,000 who are mental health specialist nurses. That's about 1% of the entire nursing workforce. Of course, all nurses are educated to provide physical and mental health care, practice holistically, but this is specifically the numbers that we were able to identify who are mental health specialists. But where they do exist, they comprise about 44% of the mental health workforce. But again, we have an issue of maldistribution. Overwhelmingly, mental health specialists are concentrated in high-income countries, and you can see the disparity there from 0.4 of a mental health specialist nurse in a low-income country to 29 per 100,000 population in a high-income country. The average is around about 3.8 mental health nurses. But we also identified issues with education. Next slide, please. We asked countries whether they had a mental health workforce plan, and overwhelmingly these countries said no, that they didn't, but that they may have. 60% said that they did have a plan to increase their nursing workforce. That's good, but it's not clear how well defined the ambitions are in relation specifically to the mental health nursing workforce within that. So even if your country says they have a plan, we need to interrogate and look closely at it to see whether it includes mental health nurses. Given this disparity in terms of needs that we've heard about this afternoon as well, the fact that 40% of countries have no plan at all is indeed very worrying. And then we ask about clinical placement hours for mental health within undergraduate pre-reg nursing education, and you can see here the distribution. As an absolute minimum, ICN thinks that undergraduates should have at least 80 hours, and I think that's a bare minimum. Even on that bare minimum, we still have 41% of countries who are falling below that threshold. And where those placements do take place, they're often in acute settings, which means that students are just not being exposed to the range of different mental health care settings that there can be. Next slide, please. And these are some statistics based on a survey specifically of mental health nurses, mental health specialists, mental health organizations as one. Mental health organizations as well. 3 in 4 respondents said that the public had a poor understanding of the roles and responsibilities of mental health nurses. 4 in 5 that the most acute shortages were in child, adolescent and maternal services. Again, there's a report just a week or two ago saying that the group in which the needs are growing at their fastest rate, mental health needs, are in younger people and adolescent populations. 1 in 3 said that there were barriers to work into a full scope of practice. This is a huge own goal when we know Madeline talked about the effectiveness of advanced nursing roles, the opportunities around prescribing, for example, but this is an area of solution that we should be pushing ahead in. And also only 2 in 3 people saying that they felt mental health specialists were involved in high-level policy making. And when we think about this equality gap I'm sure we'll come on to it in the Q&A, but surely one of the ways to address that quality gap is that we need to make sure we have expert nurses involved in the policy making process. All of these factors are also not good in terms of feeding dissatisfaction and low morale amongst mental health nursing workforce. So what do we need to do? Next slide, please. This next slide is the ICN Charter for Change. We produced this on International Nurses Day this year. We've been using and advocating widely with it. It's a 10-point plan of what needs to happen to start to improve and address some of the things that we've identified. It's not rocket science, but you can see that it requires investment. We talk very specifically about the mental health of the nursing workforce. We talk about the importance of workforce plans, supporting advanced and specialist practice, reorientating our health systems to have more of a public health, public education focus, and to give proper parity to both physical and mental health needs, and also opportunities and the need to appoint more nursing leaders. And I commend that plan to you. Final observation for me in terms of also, we know what we need to do, but also another very significant opportunity we have in front of us, colleagues, is that WHO just last year announced that there will be a State of the World's Nursing 2. We're just about starting the process of collecting data for that. It's an opportunity to focus down again on the mental health nursing workforce. And we do already have agreement with WHO that one aspect of that State of the World's Nursing report will be a deeper dive into the mental health nursing workforce. Colleagues, I'm now going to invite our panelists to join me. You have already heard from some of them, so I will not reintroduce Madam President Pamela Cipriano, Charlene, Graham, and Madeline, but I will introduce specifically Emma Waddy, who is the Deputy Director for Mental Health Nursing at NHS England. She's been a mental health nurse for 25 years with a huge breadth of experience. Emma, delighted to have you with us, and just to recognise your really significant leadership for mental health nursing in England, and I hear you popping up across Europe as well. And also to introduce Cheryl Garis Lloyd, who's a registered nurse from the Caribbean, a lecturer at the University of the West Indies, and has been a very prominent mental health advocate for over 20 years. Let me first go to Emma and Cheryl. You two are both incredibly close to mental health practice and mental health nurses. Share with us and give us some reflections on what the biggest issues and priorities are that concern them right now. Emma.
Yeah, thank you. And just want to say I'm really delighted to be part of this webinar today, and I think it really sets the scene at raising the visibility and credibility of mental health nurses across the world. So thank you very much. What I hear over in the UK, the biggest issue reflected, I'm still in clinical practice as well as my leadership role, is the concern around resources. So a lack of mental health nurses, a lack of workforce, a lack of recognition for their contribution, and also a lack of support for them in practice, particularly around continual professional development. So again, these guidelines will be really welcome at setting out some expectations around that. I'll hand over to you now, Cheryl.
Good morning, good afternoon, good evening, everyone. Thank you so much for having me. I'd say, Emma, it sounds the same. The 3 points I thought of right away would have been, maybe we need more policies and guidelines regarding what we do and how it's being done, and why we need to expand on that for mental health care services. And then I would say it's the lack of resources, human, material, infrastructure, financial. The budgets are very low, and so when you look at health overall, it's not great, and out of health, mental health is very low as well. And so it sounds as it's the same challenges that we're having regarding giving mental health care as nurses.
And Emma and Cheryl, just give us a flavour, some colour to what this actually means for the experience, for patients' experience or people who are receiving care support and treatment. What is the impact of all of these issues on that experience?
Yeah, so again, for us, and I'm going to specifically focus on England, the main issue is that people are waiting longer to receive the care and treatment that they need. So COVID really shone a spotlight, and I think in some ways did push back on some of that stigma around seeking help. And there was a real emphasis on people reaching out, recognising the mental health impacts, not just from COVID, but of course. But what has then happened is that we don't have the level of resources in order to be able to respond to that in a timely way with the specialist resources that we need to do so. So we are seeing rising demand, but also rising complexity. And then a real disconnect from mental health nurses who don't feel able to provide the care and the treatment that they want to be able to do. And that's a really difficult space to be when you want to provide care and you know people need it, but you just do not have the capacity to be able to do so.
I'd say the same again, Emma. Maybe she's reading my mind. So it looks at longer waiting times, less access to service, poorer outcomes, a decrease in our compliance rates, not being able to have more mental health education and promotion to help families and communities as well. And it also looks at the resources we need, for instance, to expand into community a bit more and or to respond when we have a crisis situation. And it also means that our clients are paying more sometimes for private care, and also sometimes the access they need to have psychological support or even the medication regimes. It's so expensive because it's not always available to them either.
Thank you both, and do not be in any way worried about the fact that you're saying the same thing. The meeting that I referred to that the president and I were at last week, it was striking the similarities that associations from different countries report in terms of the challenges that they're facing and what they're calling for to be done for support for the whole of the nursing workforce. Graham, Charlene, let me come to both of you. Firstly, to offer the huge congratulations on the groundbreaking and influential work that you've done through the Lancet Commission, and ICN has been delighted to be able to support that in a small way. You talk both the report and today about the crucial importance of the inclusion of people with lived experience in health, professional education and policy development. You include that, we know, at ICN as a recommendation as well. Could you say a little bit more about why you singled that out as a particular priority, and indeed also any thoughts that you have about what we as the nursing community need to be doing to improve education for mental health nurses generally?
Charlene?
Okay. I wasn't sure where to go. Okay. Yes, let me start. I think it's quite valuable when people with lived experience are involved actively in the education component, because I think theory is one thing, but experience is quite a different thing. And I think at that level of education, nurses learn kind of the practical side once they go out. They actually had contact. Graham previously spoke about contact-based education. At the same time, it helps to reduce stigma if people are involved in that. And when we also include it into policy, it also means that services are developed that can respond to the actual needs of people with lived experience by having provided their expertise and their experiences into it. And ultimately, if you really think of it, it's cost effective, because then services are developed based on what is benefiting the individuals, the majority. And for me, it's also important that policy then should include peer roles, peer specialists, which you also spoke about in the Commission's report. And for me, that's an important component, because I was involved, made use of public services, and I often saw the nurses are being so overwhelmed at the clinic dealing with so many patients, while a peer support or a peer specialist could take so much of the nurses' roles out, not roll their role over, but some of the nitty-gritty stuff. And I think that could be mutually beneficial.
Mhm.
Thanks.
Thanks, Charlene. So just first of all, I completely agree with what Charlene just said. A couple of other points. In principle, this is right, involving people with lived experience. The slogan is nothing about us without us, and that's really important. But also it's because of the evidence. For stigma reduction, that's what we know works. Now, I mentioned the example of the work in slums in 2 sites in India. Now, the young people we worked with, people with mental health conditions, came up with brilliant ideas. They had a hopscotch game. They had the snakes and ladders game. They had a magic show with the theme of mental health. People loved it. It's entertaining, it's fun, and it's effective at the same time. And what can nurses do? I think the first thing is to look at ourselves. In my case, medicine, but before I did medicine, I worked for 4 years as a nursing assistant myself. And for people working in nursing, is to look at pre-qualification training, because some studies show that people working in healthcare are at least as stigmatizing as people in the general public. It's hard to bite, but that's the fact. So it means running anti-stigma training programs based upon social contact, led by people with lived experience in maybe in post-qualifying courses as well for nursing colleagues.
Thank you both very much. I'm going to come to our president next. Our president has been a global advisor as part of the work to help move us towards universal health coverage, and hugely significant that we've a nurse and we've Pam who's leading that work and that effort for us. But Madam President, give us some insights in what you think we need to be doing in relation to the investment in mental health and mental health nursing to help us achieve UHC.
Thanks, Howard. Yeah, it's absolutely critical that to stay focused on the ability for us to develop better approaches that are, human rights-based, person-centered for mental health care if we're going to achieve universal health coverage. We know that we are lacking in many countries in the amount of primary health care. So the pathway to universal health coverage is to boost additional primary health care. But embedded in that is the combination of primary care married together with mental health care. So we are and the investments in the nursing workforce, which has a dual impact of investing in the primary healthcare workforce as well as the mental health care workforce, where in most places it's integrated. And it may not be in the formal settings, it's in many community settings, again, where there are not mental health professionals or those educated with extensive certifications in mental health. It all must be provided in settings across the continuum. That's where nurses are. And that's why we continue to advocate for investments in the nursing workforce, investments in primary health care as the pathway, again, to universal health coverage. They cannot be separated. They are really one and together. And so all of the efforts you've heard about today are, again, going to converge around revolution in the care of patients, individuals with mental health challenges, as well as restoring the preventive measures and removing the barriers to help us both for mental health care and universal health coverage.
Thanks very much, Madam President. Colleagues, we're going to run for about another 10 minutes. So if you're able to stay, please do stay. Please do stay with us. Madeline, I'm going to come to you next, but I would also like to get back to Emma and Cheryl afterwards as well for a view on this issue. The mental health of the mental health workforce, we've consistently heard the challenges, the issues, particularly related to the pandemic, but not just related to the pandemic, and then what the impacts could be for us in terms of growing the nursing workforce, addressing shortages and retention. Madeline, firstly, how serious is this issue in terms of mental health of the mental health workforce, and what are the things that you would be advising as the absolute priorities that we should be focusing on there?
So thanks, Howard. You gave some very interesting statistics about the prevalence of what happened after COVID. But we've had data over the years that suggest that nurses are reluctant to seek help when they have anxiety or depression or especially when they have an ongoing mental health problem. So they are stigmatized by their colleagues, and to some degree, there is stigma which is pervasive within our employment system. And this is worldwide. So we have really recently in the United States started working on new requirements that we want to bring forth to all employers, which allow nurses the opportunity without judgment to have mental health services available to them. That means getting time off. That means having nurse experts, mental health nurse experts, as people who are resources whom nurses can go to recognize that. And I think we are moving very, very slowly toward an all-inclusive approach to the need for mental health services for all health professionals. We need to attend to nursing, however, because there still exists among us the belief that nurses must be strong at all costs. Nurses must never admit to vulnerabilities. Nurses must carry on no matter what. And our educators manage to instill that in our students. Time to let that go.
Thanks very much, Madeline. But I think Madeline and both Graham have asked some hard questions that we need to look at as a profession ourselves. Emma, Cheryl, back to you on this question of seeing, you know, I'm sure every day that you're working with frontline practitioners who are feeling the impact of the mental health pressures that they're having to deal with. What would you say are the priorities for us to support them?
Yeah, thank you, Howard. So I would concur with Madeline that the inherent issues around when you are, as we all are, exposed to vulnerability and trauma day in, day out, that has an emotional burden. It's an honor, it's a privilege, but that does leave its mark on us. And I think for too long as nurses, we haven't been in a space to recognize that and therefore build into our time opportunities for reflection, for instance. Because I want to focus on prevention. We need to look at nursing cultures and how we create workplaces that promote a culture where nurses are able to thrive, where they can actually be empowered to speak out, to have opportunities around their careers, their progression, their continual professional development, how services are run, but also are enabled to speak out and reach out for support when needed. So I think for me, there is also a focus not only on those who become unwell, enabling them to seek specific and specialist mental health treatment, but a real focus on the cultures in which we know mean it's much more likely that nurses stay well and therefore are better able to care for patients, and they're kind of mirroring that space. So for us in the UK, we really wanted, and particularly in England, we've really focused on upskilling and empowering nurses with an aim for creating those cultures in which they can thrive. And we've called that professional nurse advocates, but we've really tried to focus on a prevention agenda to prevent nurses getting to that space where they become unwell.
Excellent. Cheryl.
I'd have to say again, it's sad sometimes that we have these similarities, but it's great to bring them out. So I'd say the culture, one in the education, as Madeline said, we need to stop sharing and teaching that we put everybody first and put ourselves last. So nurses are the care in healthcare, but we don't teach self-care. And I have a phrase I like to say that selfish isn't always a bad word. That's when it's called self-care. So we have to be our best selves to be our best caregivers. And then again, I talk about the practice setting. So there needs to be ways for us to care for ourselves, to build resilience, to do well-being practices. And we have to be willing to do that individually, but we also have to advocate to have our employees and institutions look at ways in which we can build on that. There are simple things we don't have. You work in a setting where privacy and confidentiality is important, but when you've had trauma, you don't have an opportunity to debrief. Who do you talk to about that, and how do you do that? Working in nursing and mental health nursing in particular increases our risk for compassion fatigue and burnout. What do we learn about that and how to prevent it? And what are the simple things we could do sometimes to be able to prevent that? Because that also leads to the nursing shortage. If I'm burnt out and tired, I'm going to want to leave. And then how do we provide care for for our patients. So we need to look at a couple of simple things that we could really do. You know, having a nature experience, having a green area, giving us the tools to help ourselves and also to support each other. I'd like to say maybe one of the things is consistency. We have to do something for ourselves every day, and we have to keep lobbying and advocating every day until we get to where we need to be as the caregivers so that we are our best selves.
Cheryl, thank you very much. Panelists, your final job. I'm going to give you one sentence, and you have one sentence to complete this tweet. The tweet is, to effectively transform mental health care globally, we must. To effectively transform mental health care globally, we must. Charlene, complete the tweet.
Focus on quality of life as outcomes, not only clinical outcomes.
Brilliant. Graham.
Focus on the mental health of mental health nurses so they can do the job to help others. Where people want to disclose this and talk about their problems and seek help, fine. Where they don't, train middle managers so they can receive information from people with mental health problems in confidence and refer them on to get the help they need to be a sustainable resource for global mental health.
Madeline.
Truly embrace that mental health care is a human right. While we can't always provide that care ourselves, we can facilitate the recognition of that human right and change the systems that also provide that support.
Madam President.
Take urgent action to secure the investments to prepare nurses to be able to be the global workforce for mental health.
Cheryl.
We need to do more mental health education and promotion across nursing, healthcare, and the public.
And Emma.
We must give it equal parity and focus to physical health, recognizing the critical value of specialist mental health nursing skills, supporting and retaining them in practice to support communities.
Excellent panelists. Expect to see those tweets emerging very soon. I can hear our my communications team applauding in the building that I'm in, and sending their thanks for helping them with their work today as well. They were superb. Thanks on behalf of us all to you, our panelists, and I'm now going to hand back to our president, to Dr. Pamela Ciprianos, for her closing out thoughts and remarks. Back to you, Madam President.
Thank you, Howard. And let me also add my thanks to all of the presenters, and certainly for all of you who have attended the webinar, for your sincere interest in boosting the mental health care around the world. I would encourage you to double check the chat. Some of you asked questions about where the resources will be. Many links have been put in the chat, but also we'll share the information and recordings on the ICN website if you go to the events area. So be on the lookout for that. Today, we've really heard a call to action that we must really understand that our efforts are a testament to the ongoing commitment to improve mental health care worldwide. And so we know it's really important that we address the global burden of mental health disorders and underscore the urgent need to invest in the mental health nursing workforce. We've also heard that it's important for us to encourage our colleagues to create a personal and organizational plan by sharing the information in this webinar so that together we can remove the barriers that will allow us to provide person-centered, human rights-based approaches to mental health care, taking into effect the integrated lived experience. It's our hope that you have been stimulated to think about some other ways that we can, again, enhance what we do, help our students, look at answering some of the tough questions of why we have not created the culture that allows people to overcome the stigma, as well as how do we become more sensitive in terms of how we interact with those we serve. This is a critical time for us to be sure that we are doing all we can to build a more effective, equitable, and humane mental health care services system for all. So thank you very much. We hope you will rapidly incorporate any new knowledge that you learned from today's webinar, as well as utilize the many resources that were provided by our incredible speakers. So thank you to everyone.
and wish you a good day.